Yeah, so the other thing that I would just also mention on this is that when people go to their primary care physician and they start complaining about some of these problems, I have aches and pains, I'm having trouble sleeping, they're going to give them something like a minor tranquilizer, which is going to be like benzodiazepine or Xanax or something like that, which is probably going to make the situation worse. And so that's the reason why we think it's really important not only for the primary care physicians to get a better understanding of depression to make sure that they're also diagnosing it, but also for us working out in the community to make sure that people that we're working with actually understand what they're really experiencing, so that when they go see a physician, they're not necessarily going to be given something that might potentially make things worse.
On patients that can sleep, we give them Elavil.
So the question is about using Elavil. And so Elavil or amitriptyline is actually one of the original antidepressants. So it can be used in terms of helping patients sleep. And we also, and as we'll probably, I think later on in the talk there are some other examples of when it might be okay to use a sleeping agent with other antidepressants. I think that the main thing is that you don't want to give this alone. You want to make sure that you're giving some type of appropriate treatment if you're using medications. So with antidepressants, we know that amitriptyline has antihistamine effects, which are going to make people go to sleep, just like if we were going to give somebody Benadryl, like if we're taking it for a cough or a cold. If we're taking antihistamines, we often will feel sleepy with it. So these things are helpful at low doses, and then also if we're using it at the higher doses, which are more appropriate for treating depression, amitriptyline would be a reasonable choice. The one reason why we don't use amitriptyline as often these days in terms of treating depression is because we have other medications that have better side effect profiles than amitriptyline, and particularly in the elderly, amitriptyline does not necessarily work out so well, particularly for those people who have incontinence problems, or again, might be affected much more strongly by some of the side effects that happen with amitriptyline.
And the other one is the risk of overdose.
That's right, and the risk of overdose as well. So the one other thing that comes up with using some of these older medications is that it can actually affect the cardiac rhythms in your heart. So if you're taking high levels, it actually can interrupt your heartbeats, and so that can lead to sudden death. And so, this again, while it's a medication that we would normally use to, work on depression and also to prevent suicides, I mean, at some point, if somebody's overdosing on these medications, it can lead to a very bad situation. So this is the cycle of depression, and so as you can see here, we think about depression as being in the center of this, and you can see that there are all sorts of different things that potentially could affect depression. So there are stressors such as medical illnesses, family problems, work problems. These are all things that our patients are experiencing, and that when they have these stressors, these can lead to these sort of negative thoughts in terms of thoughts and feelings, low self-esteem, sadness, hopelessness. And it can also lead to physical problems in terms of poor sleep or pain, low energy, or poor concentrations. And then these lead to other types of behaviors that we start noticing among our patients or clients in terms of social withdrawal, decreased activity, and decreased productivity. And so at some point, these all sort of cycle back through again, so you can see that these are sort of bi-directional arrows. So when people are experiencing these same sort of behaviors, this sort of feedback upon itself and becomes a sort of negative feedback cycle, and it just gets worse and worse. So on one hand, when we talk about people feeling down, I mean, we all feel down at some point. We all have experiences that might make us, feel unhappy or sad. But at some point, when things get pushed over to a point where it moves into this negative feedback cycle and things just get continually worse and things don't improve, that's when we have to start thinking, are we moving more towards depression? And that's the reason why we thought it was important to make sure that we talk about some of these other conditions like bereavement or adjustment disorder, because we know that there are events that can happen for all of us that might make us feel down, but it wouldn't necessarily make us depressed. At some point, if things continue to persist and are severe enough, at some point, we would want people to seek treatment. So, talking with caregivers about depression. So, not only should we be talking to our patients, but the thing is that patients are embedded in social structures, and we know that not only do we need to talk to our patients, but we also need to talk to other people who are working with them, who are caring for them, and particularly in the example of the elderly who are homebound, people who are providing care for them too. So there are certainly patient education materials such as booklets and videos, and we had some of the booklets back in the back that you now have that can aid caregivers in terms of recognizing some of these depression symptoms. In addition, caregivers may have a better view in terms of the patient's moods and some behaviors and changes over time. We only see what happens to clients or patients when they come into the office, but we won't really know what's happening at home. And so for that reason, it's really important to try to recruit everybody to focus on this. The final thing is that is something that we had mentioned earlier in terms of looking at some of these symptoms. Common symptom for depression among men is irritability or anger. So in terms of supporting antidepressant management, it's important to make sure that we're familiar with the commonly used antidepressants and their medication dosages. And we also want to make sure that we're providing basic patient education about antidepressants. We also want to make sure that patients continue to take their medications, because probably the biggest thing after starting patients on treatment is that usually patients stop. And we want to make sure that patients continue on with their treatment, because if they continue on with it, they'll get better. And then finally, it's important for us to know when treatment isn't working and when we have to make a change.
Will you be discussing that?
Yeah,
Yes.
absolutely.
So the other things that we want to make sure is that we want patients and providers to know when we're using inadequate doses, because we oftentimes will start medications at low doses so that they get used to it, and then we'll slowly ramp it up. But oftentimes what happens is patient gets started on a medication at a low dose, often in the elderly because we're concerned about side effects, and they stay at those low doses, and the medication never changes. And they're taking these low doses that aren't helping them, but they're continuing to take them. The other thing is ineffective treatment in terms of making, we know that, there can be persistent depression after an adequate duration of so even after we try an antidepressant, it might not necessarily work, and we need to make sure that we understand, is this really working? Do we need to continue the treatment longer? We shouldn't just stop the treatment just because we think that, there's a certain set time period that medication should be effective, and at that point we can stop. There are also side effects that we also want to be aware of. And then we also want to make sure that we really help doctors and other types of providers work with their patients in terms of talking about the problems with their antidepressant medications. Because oftentimes, as I mentioned earlier, when a patient goes into a doctor's office, if they have 10 minutes with the doctor, this might not come up. If they're going to talk about 5 issues, this might be issue number 4. They might not get to it, and so we want to make sure that at some point, if somebody's prescribing the medications and there are some problems with it, we want to make sure that they're aware of it so that they can change course if it's needed. And then finally, if there are additional problems, particularly with the way that we use the collaborative care model, there's always backup for providers. And so a common complaint that we hear from primary care physicians is that they're uncomfortable with, what happens if we run into complications, what if people are not responding. There's always somebody that you can tap into. And I think that with the collaborative care model, not only, do we have the whole team, working with a primary care doctor, working with a therapist, working with the case manager, but we also have, additional backup steps in terms of having somebody there like a psychiatrist who can, work with those cases where things don't seem to be working under the initial regimens that we suggest.